diagnosis workshop in acute ischemic stroke. In the previous workshop, we had very unique and interesting case discussions, and today we are looking forward to have a fruitful discussion as well. The objective of this workshop is to showcase unique cases in acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. And with this, let me introduce our faculty for today. I am sharing my screen. So first, is my screen visible to everyone?
Yes.
So first, I welcome Dr. Ichapuria, our course director. Sir is director at neurology at Sahyadri Hospital, Pune. Sir has the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. Sir has more than 300 public lectures and workshops on stroke. Sir has been member of Indian Stroke Association and the organizing president of StrokeAthon 2012 and also the organizing president of ISS Stroke School. Sir has been ex-president of Society of Neurosciences Pune and Maharashtra Academy of Neurology and also a founder of Pune Stroke Group. Sir has also been a principal investigator for many multinational stroke trials like PERFORM trial, and he has been recently awarded as Health Icon by Times of India Group. Welcome, Dr. Ichapuria, sir.
Thank you so much.
Then I welcome Dr. Anshu Rohatgi. Sir is consultant neurologist and professor of neurology at Sir Gangaram Hospital, New Delhi. Sir has been the secretary at Delhi Neurological Association from 2021 and onwards. Sir is also a joint secretary at Association of Neurologists in Clinical Research, Mumbai. Sir is coordinator at National Accreditation Board for Hospital and International Organization for Standardization for Neurology. He has been a principal investigator in more than 24 studies. Sir has more than 47 publications in various reputed national and international journals. He has presented more than 25 scientific papers at various conferences. Sir has also been a guest faculty at many prestigious neurological meetings and conferences. Then I welcome Dr. Pratik Sharma, our second moderator for today's workshop. Sir is a senior consultant neurologist and chief of stroke unit at Bansal Hospital, Bhopal. Sir has more than 15 years experience of neurology. He has been a member of Indian Academy of Neurology, Indian Stroke Association, Indian Epilepsy Association and Society, and also a life member of Indian Academy of Pediatrics. Sir has contributed in multiple chapters in book published on the occasion of International Headache Conference in 2010. He has also contributed to different modules for elsewhere clinical learning program. Sir has special interest in stroke and pediatric neurology. Then I welcome our first speaker for the today. That is Dr. M. Abid from Chennai. Sir is consultant neurologist at MGM Healthcare, Chennai. He has more than 7 years of experience post DM. He has been part of multiple studies and also has presented 6 papers at various national conferences. Welcome, Dr. Abid. Then I welcome Dr. Pradeep Tiwari, our second speaker for today. Sir is consultant neurologist at MGM Hospital, Vashi, and the areas of interest are stroke, epilepsy, cognitive disorders, nerve muscle disease, autoimmune neurology, headache, and pain medicine. So with this introduction, I would like to hand over this session to our course director, Dr. Ichapuria sir, for his opening comments and context setting. Dr. Ichapuria sir, over to you.
Yeah, thank you so much. We've had some very exciting previous meetings, and we've discussed very interesting cases, mainly from younger colleagues. And I'm extremely happy to see that stroke thrombolysis has penetrated far and wide and deep into the Indian subcontinent. And I think programs of this type, discussing cases, there's so much to discuss. You may think the case is very easy and very simple and there's nothing to discuss, but there's a lot to talk about and a lot of new ideas come up. And I've learned so many things from my younger friends. And I'm sure the moderators also will enjoy this program. Anshu, are you there? Is Dr. Anshu there?
Sir, he has not yet joined. He will be joining in some time.
Okay.
He's just
Dr. Sharma, I think this is the first time you have been a moderator. So I would like to hand over to you for a few words before we start the first case. Dr. Pratik.
Good evening, sir. It's a proud privilege for me being sitting with Dr. Nasil Ichapuria. You're correct, sir, that I am the first time I am getting this opportunity to be moderating a conference or kind of webinar, which is been going to be attended by almost throughout the nations, different from faculty or even from neurologists. So first of all, this just being a person who has been involved in a stroke, we always been want to talk and discuss and learn from all the person who is going to participate in this talk. So, okay, stroke is a very important emergency, and I will request first the speaker to please to deliver his first talk and discuss that case.
Yes, Dr. Abid, I think you can start your case. You can start the screen sharing and get on.
Yes, sir, going ahead. Yeah. So, are you able to see the screen?
Yes, clearly.
Yes. Good evening to the members and the respected teachers in this forum. I'm here presenting one of the interesting cases which I've done in the last week in our hospital, MGM Healthcare. It is a tertiary hospital located in Chennai. And we have this 71-year-old lady who came to the ER at morning 9 a.m. With a symptom of dysarthria which lasted for 2 minutes and found to have an increased BP of 190/100. And at the time seen by us in ER, we have advised admission for the patient. But the patient claimed that she was dysarthric because of her edentalous nature and fever that she had for 2 days, and she refused an admission. Being an elderly person, we insisted on admission, but she went home on the same day. On the same day, when she as soon as she went home, she slept and got up at 5 p.m. and found to have worsening weakness of the left side. And she came to the hospital at 7 p.m. She's a cardiac patient, so she went to the cardiologist OPD directly. And at the cardiac OPD, her NIHS was 4, and she went all the way herself in the wheelchair. She was lifting, and suddenly in the cardiac OPD, her NIHS deteriorated to 15, and then we received her ER at around 9 p.m. and then the stroke code was activated. This was the presentation when she was in ER. She can be seen communicating. She was lifting her right upper limb. She keep on insisting she was not able to hit the left upper limb. There is a facial weakness which we can see. The score is, by the time we received her in the ER, she has deteriorated when it is 15. Now, she is not able to lift her lift the left lower leg. So, as that immediately echo was done for her, and it was having the same features of anteroseptal MI with an ejection fraction of around 32%, with an baseline investigation so normal, as she had expected the thrombolysis time period for us, because she presented to us with at 9 a.m., then there is a deterioration at 4 p.m., again there is a deterioration at 7 p.m. So we thought we will go ahead with the MR protocol for this patient. And as the MRI was done, there was showing a diffusion restriction on the right MCA territory, but the flare was not having frank changes. So we went ahead and did the ASL sequence for the patient, which shows that high parietal region, the motor cortex was getting still some blood supply through the collateral supply through the other territory. And the susceptible weighted images clearly shows the thrombus sitting on the distal M1, which is probably a red clot, which is sitting on the distal M1. So we decided to go ahead and do thrombectomy for this patient as she was deteriorated within the hospital. So as she was out of window period, so we went ahead and we planned for a thrombectomy for this patient. The patient was taken to the cath lab by around 10:30, and so what we did not all thrombectomies are so easy. Actually, we had to use multiple materials for this patient. We used Cerebrace catheter, ACE penumbra, 3-max, own 4-wire, and we have to try this extraction of the clot by using 2 stent retrievers. Basically, first, what the problems which we encountered in this case, initially the plan was to aspirate this clot because it was a red clot. It was sitting in the distal M1. We thought to initially try to aspirate the clot. But the thing what happened when we put the catheter, the guide catheter inside the ICA, it did not take the ophthalmic bend, and it was IS68 was stuck there, and it did not come out. And so we thought of trying to push the 3-max and try to engage the clot and try to suck the clot. It did not happen. So what we thought, we will take an aux solitaire and try to cap the clot, since we are not able to suck the clot. But 2 times when we tried with solitaire, we were not able to catch the clot. It was it's a difficult one. Though we opened a new stent retriever embotrap and we tried to capture the clot, and little bit of antegrade flow was seen, but and it was showing again antegrade flow was getting on reduced in subsequent angio runs. So that is the time we decided to go out with intraarterial tenecteplase was given about 4 mg. We gave it anteriorly, and I will just guide you through what was the patient, how was it. This was the angiogram of the right MCA. You can see there was no flow on the other side, and the collaterals were also not filling up the territory on that other side. So this lack of collaterals, we decided to go and open it up. So as we did the microcatheter injection, the thrombus was clearly visible in the AP view. It was sitting in the distal M1, both in this is the lateral view, which also shows the thrombus sitting in the lateral view. And so we decided to go ahead and do the AS68 was stuck here, somewhere here. We have the AS68 was stuck here. It was not crossing this bend actually. It was stuck here, and it was not crossing this ophthalmic bend. So we went ahead with the 3-max was just here, and it was not engaging the clot. It was just here because we tried to push, it was not going in. So we went ahead with the stent retriever, and this was the embotrap, and we did the clot retrieval, and the clot came out. But by the time this procedure was over, it was about 9 hours since the onset of clot came out at 2 p.m. But recheck angio, you can still see the clot sitting in. There's a clot sitting in at the distal M1, and there is some antegrade flow, but it was about to close. Every time we take a repeat angio, it was closing down. So we gave intraarterial tenecteplase at that time. About 4 mg we gave it. 4 mg we gave through the microcatheter, and following which there was no further closure of the vessel. We thought it's almost 9 hours since the onset of stroke. We just thought we'll stop the procedure, we'll come out, and we decided to monitor the patient in the day 1 post-op. The TCDs were showing good MCA flow after the intraarterial tenecteplase. In the day 1 and the day 2 post-op was also, the patient was having good MCA flow. And subsequently, we repeated the CT. Since it is a patient has an improvement, patient is under rehab, the NIHS has improved to 8, but still there are areas of hypodensities because of the time delay we had. But what is definitely is there is no bleed actually, and after the intraarterial tenecteplase, and the patient.
Sir, you're not audible. Dr. Adi?
डॉक्टर अजिंक्य, एक बार डॉक्टर को फोन करना पड़ेगा आपको.
हाँ हाँ.
Rehab. So, and yes, NIHS has improved to 8 actually. So, shall I go on with the second case or is one case?
Let's discuss this case. Dr. Sharma, would you like to say something?
I just want to ask Dr. Abid that how much experience you have of intra-interconnected days, because right now everybody using is the suctions and thrombectomy. You have gone ahead and done the 2 or 3 and 4 things ultimately to save the patient. So it's quite a commendable work from your part. But yes,
Sir, the experience is coming from my training place at EMS Cooperative Hospital, Perindalmanna. Okay. Are you able to hear me, sir?
Yeah. You are audible.
Yeah. Because I have got my training at 2 places actually. One was in Zurich and the second thing was at EMS Cooperative Hospital. What we do there, we have tried a few of the cases, about 6 to 7 cases. The trial is on. We have started with the thing where we use intra-arterial thrombolysis for tenectase especially, and we have done about 7 cases there. And the results are yet to be published, which we are planning to do for about 15 cases there. And until now, all the 7 cases are doing fine. And where especially we do it, especially those cases who are crossed that window period, but you still find the thrombus is sitting there even after all your maneuver is still there. We have been successfully given about 4 patients to 6 patients intra-arterial tenectase. And there is no such bleed as such, and patients, that clot has dissolved in front of our eyes actually. So with this experience only, I went ahead and gave intra-arterial tenectase to this patient actually.
Thanks for sharing your experience.
Yeah. So this is not mentioned anywhere because it is a in hospital knowledge we had. I had it, so I had to go ahead with it. And in spite of nobody does it actually with the stent retriever in, you remove it and then you give a tenectase. It's little risky, but we have to take the risk because it is life-saving for us.
So I missed the first part. So you gave an intra-arterial tenectase?
Yes, sir.
And what dose was?
4 mg, sir.
4 mg. Are there any? Dr. Ajinkya, are there any guidelines for giving this intra-arterial tenectase?
No, there is no such guidelines actually, sir. There is no such guidelines for giving the intra-arterial. There is one trial which they are doing, giving this intra-arterial tenectase. They are given about 1 or 2 mg. We went and gave 4 mg for this patient.
So like 4 mg is a dose. How did you decide the dose? That's what I'm interested in.
No, actually, any of the arterial dose which we give, so whatever the arterial dose we give, it will be 1/4 of the intravenous dose. That's how all this arterial dose are all calculated. It's 1/4. So I just 1/4. So that's what when you do give intraarterial nimodipine, it is all 1/4 of the dose. So with that hunch, I went ahead and go. We used to do that in our previous hospital where we give 2 mg, 3 mg. So we went ahead and I went and go ahead with 4 mg of intraarterial tinnitus.
Okay. Don't you think that the risk of bleeding would be higher? Like you have already done the
yes, sir. Bleeding risk is high. But if it is not done in a tertiary center, where would have been able to do this? We have an in-house neurosurgeon who can back us up and make the patient understand that we are ready to do this to save the neurons which are at risk. And which in such an NHS which got improved from 18 to 8, I feel that whatever maneuver is done in a case-to-case basis is judgeable.
And you're not using any intravenous antiplatelets or intraarterial antiplatelets?
No, sir. We didn't use for the next 24 hours. We didn't use, since we have done intraarterial tenectase. We didn't use any sort of any heparin or antiplatelets for next 24 hours. It was reinitiated after a period of 24 hours, actually. We started with a single antiplatelet and anticoagulants were also continued.
Yeah, Dr.
Because of the head. Yes, sir.
How did you calculate the stroke onset time?
Sir, actually, the first episode was at 9 a.m. actually. Then she got up, she came directly to OPD. That whatever is this is history only, sir. By the time we received it,
it's always history only.
Yeah. So by the time it was in the cardiac OPD, they said she was able lifting her left hand, left leg, and only seeing the dysarthria has worsened. By the time we received in casualty, it was 20. NHS was 18. Sir.
Yeah. So what is the stroke onset time?
Stroke onset time is in around 4 p.m. Sir. Around that 4 to 5:30 p.m. in between that, where she was in the cardiac OPD.
No, I would think that it is when she came in the morning, no?
Onset is at the morning, sir, but she refused.
Yes. So that is the stroke onset, no?
Worsening was stuttering like...
yeah, it is stuttering, but that is the stroke onset.
Okay.
And why do you think it was stuttering? You think it's a ICAD or you think it's embolic or what?
Sir, it is ICAD with a thrombus over it.
Yes. So most likely it's an ICAD. Now, in your MRI, you showed a very large area of diffusion restriction.
Yes, sir.
And even on FLAIR, there was a signal. Is that correct?
Yes, sir. Mild signal changes plus 50 plus minus.
No, but there were.
There
was not. It was not a normal FLAIR.
Okay, sir. Fine.
Was it a normal FLAIR?
Not a normal FLAIR.
It was not a normal flare. So actually, that means that the stroke onset time is quite large, at least more than 6 hours, definitely, or definitely more than 4.5 to 5 hours. And there's a huge infarct. So actually, it does not meet the dawn and diffuse criteria.
No, sir. The purpose for doing this case was that ASL sequence on the right high parietal region was still having its penumbra preserved. That was the cortex area, and if you had not saved the cortex, the limbs would have gone for.
But how do you know that the cortex is not involved? Have you done this thing? Have you done a perfusion scan?
Yeah, that's what. So I put the perfusions.
So I think they're using ASL rather than a perfusion scan.
Yes.
Can you show us the ASL?
So is there a big mismatch?
This was the ASL.
Can you show the ASL?
The one on the top. Are you seeing it, sir?
You are not able to share your screen. I think you share your screen.
1 second. Yeah. Now you are able to see, sir?
No. You have to share the screen again.
No, but how much was the mismatch, Dr. Abid?
1 second, sir. I'm sharing the screen. So his mismatch was about
Just slide.
Yeah.
Yeah.
So the opposite area which was having a perfusion mismatch was there actually. So the
Now
cortex
see,
and
the diffusion shows the whole MCA getting involved and sparing the basal ganglia. Is that
Yes.
correct?
Yes, yes, sir.
And now the ASL is showing that it is more or less the same area.
But that, okay, sir.
I think the ASL is also showing the same area getting involved.
Actually,
ASL
it is
was
not
having a
meeting the
perfusion
diffuse criteria. And the volume of the infarct is definitely more than 50 ml or 60 ml.
It is more than 50 ml, sir.
I think it must be around. I think 72. It must be around 70 to 80 ml.
Yes, yes. So
70 to 80.
so it's a large area of infarction, and it's already 6 to 7 hours.
Yeah, even the flare, it is quite evident, sir. I think flare is also showing.
Yeah, flare shows the thing.
It's
If you can
very
just adjust the thing a little better,
I think
we'll be able to see.
yeah, we are able to see on. I think it's pretty.
Yeah. So
Yes,
also
sir.
the other point is that tenecteplase, which you gave intra-arterially,
Yes,
it did
sir.
not open up the inferior branch.
No, sir.
Correct.
Inferior branch was not opened up, sir.
So actually it didn't open.
No, sir. No, sir.
What was opened was by the device.
Sir, what? But it was no, sir. It was re-occluding actually. Even after opening, it was
Yeah, but then
re-occluding.
finally you showed that it has opened, no?
No, that was the last picture of that, and it was re-occluding. I said that when we opened it up, it got re-occluded once.
But then finally did it open after re-occlusion?
Yeah. It opened up after with tenectase. It opened up.
Okay.
It was opened up and maintained.
Only the superior branch opened up. The inferior
Yes,
branch did
superior.
not open.
We did not open because it's already 9 hours into the event, and so
So
we
you know
thought,
this is typical of ICAD because it keeps on occluding, and very often you have to put, because it's a focal lesion. So even after opening, it keeps on re-occluding. So many times we have to put in a stent there and give tirofiban. At least that is what we've done in few patients.
I think that's what I think. So most of the time that we have a significant ICAD, you have to put in a stent because it normally gets closed.
Yes, it gets
And you have to
closed
use-
again and
And
again.
you have
So
to use this
probably
intra-arterial.
that has happened. And probably that has happened. Dr. Sharma, would you like to pitch in?
Hello. Yeah, that's for sure that this is the ICAD lesion and stenting would have been a better option.
Yeah,
And,
little loudly, sir.
So definitely, sir, already clear was showing that diffusion mismatch. And, so there was ICAD lesion and better option would have been stenting it, and is already more than 6 and 7 hours that we have discussed.
Very informative case for discussion.
Somebody is
Mr. Sohail, you should mute yourself.
Very super.
Yeah. So, do you have the MRI post MRI? You showed the CT scan. CT scan did show an infarct, no?
yes, sir. The thing is that first when we did the stent retrieve, it got closed. Then we gave it tenecteplase, it opened up and was maintaining, which we followed it up with TCDs on the subsequent day 1 and day 2. The flow was
Yes. That you showed very beautifully. Yes. No, I think we should congratulate you on this case. But these few gray areas are there where I don't know whether I would have intervened in this case. Anshu, what do you think?
Personally, I want the
I
forum.
think it was fraught with danger. You were lucky to get away.
Yes, I want the forum's opinion on this actually. Sir.
I think you were lucky to get away because first of all you did not meet the criteria of dawn or diffuse. Then you did the procedure. Fortunately, nothing happened, and then you gave an intra-arterial tenecteplase. You're very lucky that patient did not have a bleed or anything, because such a large infarct with very very high likely of a bleed. So I think
the entire thing was.
I think you are very brave. I think interventionists need to be brave.
The only thing was that patient attendants were very pro for this. Actually, they were from US and they were very pro for this.
Anyway, I've just a little, Dr. Ichapuria, just a little question. We recently had a patient. He had a AF. So he had infarcts in two different territories. One was in the right PCA, another was the left cerebellum. Both moderate size infarcts. So what do you do in this situation? You really, do you thrombolize? Is there any guideline for that?
No, that means it is in the same territory. It's in the vertebrobasilar territory.
No. It's in the vertebrobasilar territory.
Yeah,
that's
and
right.
one embolus has gone into the cerebellar arteries.
Yeah,
and one has gone into the PCA.
Right PCA and left cerebellum.
Yeah. So, it's gone through the basilar system.
Mm-hmm.
Cerebellum is involved because of one vertebral branch, either pica or ica or something got involved. And yes, I would thrombolize if he's in the window period.
Okay. That's what I just wanted to know. Is there any specific guidelines? I tried to look up.
It is in one territory only, no, Anshu?
Yeah.
Yes, Dr. Abid, could you go ahead with the next case? I think we've discussed this case. But I agree with Dr. Anshu that you were brave. I don't know if I would have taken up this case. I would have said, ye to abhi late ho gaya. And infarct is big, and the ASL also shows, it's not convincing that, there was a mismatch. The flare also has shown that there is an infarction already. So maybe I wouldn't. And you required number of passes to open up the thing.
Four passes.
Yeah, so the real benefit comes when you can do it in one pass and get a TICI 3 or 2B or 2C at least. When you do many passes, then there is injury to the vessel wall, and then they don't do so well. So that is the problem with this case. So Dr. Pratik, would you like to comment, please?
Yes, definitely. From the start, we are saying that he's been brave to do that. And the problem is that there are multiple issues, that there were occlusion was there. He has done what Dr. Anshu is saying, that the good part is patient had done well. Otherwise, there are many question marks in this case. So yes, it's very difficult case, and we should congratulate him that he has done taken this case up. Otherwise, this is not the easy case to deal with.
Thank you, sir. My sincere request to whether by doing such, have we really prevented him from going to decompression? Normally, when such patients would have gone for decompressive craniotomy, right? So still opening the thrombus, you give an alternate chance for all the tissue toxic edema to drain up.
Yes, but she's already 71 years of age. So, decompression works in them, but it doesn't improve the quality of life. It may save life, but, they are disabled, and they have a lot of cognitive impairment, and the family has to take care of them. So we are a little careful age per se is not, it's not a contraindication, but the results are not so good with advancing age. Now, we don't know her cognitive status before, and we don't know what was her level of activity before. If she was very active and very, working, and so, if she was a good 71, I wouldn't hesitate in doing craniectomy. But, it all depends on the pre-morbid status. It depends on the family environment, the social environment, the economic situation of that family, whether they would be able to take care, because there will be disability. There's no doubt. It's just a huge infarct. There is going to be disability, even though it's on the right side. In fact, they have more cognitive impairment. NIHSS will be a gross underestimate of her deficit. because if you do her cognitive study, she will be very cognitively impaired. So, in all spheres, dressing apraxia, recognition, hemianopia, all of them add up to the disability. And she would need care for daily activities. She would be in bed or maybe just walking a little bit with a walker or something, incontinent maybe. So it all depends on the family situation. And so on a case-to-case basis, we'd have to decide. But in general, they will do worse than a younger person. I mean, in any individual case now, we don't know. But in general, as a general statistical rule, they would do worse.
Okay.
And the MRS may not come up to even 3. It may remain at 4 or 5. So these are it's a difficult this thing. It's a ethical issue. It's an emotional issue. You have to take the family into consideration, what they feel, and so many things. Money, by doing all these devices. I mean, I don't know if she's a railway employee. Maybe the railways are paying for it. That means we are paying for it with our railway ticket. But in the place where I work, people have to pay, and so it damages the family, financially also. So many considerations are there, many things to think about, many things, and you can't talk all this with the patient, because you are in a hurry to do everything. But these problems surface after 2 or 3 days when the bills rise up, when the disability is there, patient is on the ventilator. So I am a little skeptical about all these things. Yeah. Any comments from the moderators? Anshul?
No, I think you are right, sir. Actually, the thing is that sometimes it's a very difficult decision to make. And I think Dr. Abid made a very good point that maybe he averted the hemicraniectomy.
Yeah.
I think that was a very valid point. I think that because the morbidity with hemicraniectomy is really too much. And so I think that's very valid.
Okay, let's go on to the next case. Abid, do you have your case, second case?
The second speaker, sir. I have presented only one case.
Okay, you have one case only. Okay, Dr. Pradeep, it's a pleasure to see you. I've heard about you, but for the first time I'm seeing you. So it's a pleasure to see you and welcome to this forum. And you can go ahead with your screen sharing and presentation.
Thank you, sir. Thank you, sir. Is my screen visible?
Yes.
Yes.
Yeah.
So good evening, everyone. I am Dr. Pradeep Tiwari. Here I present a very simple case, but then there's always a practical difficulty in thrombolysis. So here we have a 62-year-old female. She's a known case of hypothyroidism. She's on Eltroxin 75. She's a housewife and she's morbidly obese and she has no known addictions. She came with sudden onset unresponsiveness when the attendants were trying to wake her up around 7:30 a.m. in the morning. So the patient has arrived in the emergency room with a drowsy state and there's some response to painful stimulus. So on painful stimulus, it was in the hospital, it was found that she had no movement of her left upper limb and left lower limb. BP on presentation was 190/100. GCS was poor. It was around E2, V1, M5. So there was the intensivist always advised me that we should go for intubation, but I actually did not intubate her. NHS was more than 25. And so this was the MRI that we got done. This is a video of diffusion and that I am playing here. So we can see that there's a right side MCA territory, in fact, involving the capsular region that has started to develop. But the FLAIR images did not show any change, did not show significant changes. We obviously went ahead and did her MR angio. So the MR angio definitely showed a proximal MCA territory infarct, a proximal MCA territory occlusion. And with this, obviously, what should we be doing next? Most of the people will say ki with a high NIHS and proximal MCA occlusion, we should go for mechanical thrombectomy. But the setup I work in, most of the patients are not very affording. And similarly, like the ASL sequences and...
No, she came within how much time?
She was a wake-up stroke, sir.
She was a wake-up stroke. Okay.
The time of onset was not known.
Okay.
And in our setup,
so from the MRI, what do you think is the time of onset?
Sir, definitely it should be within 4 hours because flare changes have not started yet, and diffusion is showing a restriction of in the right MCA territory.
Yeah, just show it again. Just show it again.
Yes, sir. The video is playing.
So not a very big infarct seen on the diffusion, huh?
Yes, sir.
Not very big.
Yes, sir. But the MR angio showed definitely
that is true.
Yes,
so not a very big infarct seen. Yeah. And flare, just show those changes.
Sorry.
Just can you enlarge it a bit?
I don't think it will be enlarged possible because it's basically.
Yeah. Okay. Okay. There are some changes, no, on flare, or
yes,
there's
sir.
nothing.
No, so there are changes, but that was not as significant.
No, but there are.
Yes, sir.
It's not that it's totally normal.
Yeah, I think there are some flare changes.
Yeah.
Yes.
Yeah. Okay. Okay.
So because of economic constraint, we obviously we gave her an option of mechanical thrombectomy, but she wasn't affording. So there was no other option. We had to thrombolize her. And we first gave her 10 mg labetalol, and BP was reduced to around 170/90 with the 10 mg labet. And we thrombolized her with tenecteplase. Now the problem was this first practical difficulty that came here was first was the NIHS. So NIHS was going beyond 25. So whether NIHS is a good predictor of outcomes, that is a big question here. And her weight was around 95 kgs. So practically speaking, the 0.25 dose per milligram per kg was exceeding beyond 20. But there's no fixed guideline about it. But I preferred giving her just 20 milligram of tenecteplase. And I lysed her by around 9:30 a.m. with door to noodle time was around 40 minutes. So this was the patient, and intubation was advised. However, this was not done. Now, post thrombolysis, 24 hours, amazingly, she showed a significant improvement, and lower limb power had improved much well to around 3-5, while the upper limb had improved to 2/5. And GCS was also, significantly improved to around E3, V4, and M6. 24-hour post-lysis CT did not show any hemorrhagic transformation. There was a risk of raised ICP, so the neurosurgeon was informed, and there was preparation for DHC, but it was, we did not require the need for this. There was no further deterioration, and slowly she, in fact, kept on improving. So we definitely went ahead and did a CT angio for her. A 5th day post lysis. 3rd day, she was, she was able to swallow on her own, and the Ray's tube was also removed. And 5th day, power had actually improved to around 4/5 in lower limb and 3/5 in the upper limb. And 7th day post lysis, she was advised discharge, and she was kept on dual antiplatelets and atorvastatin. So this was a CT angio that we did 5th day post lysis. And definitely there's a recanalization of the MCA artery here that we can see with tenecteplase infusion. So 2 things I wanted to sir to let me know. Ki NIHS should first why the NIHS was bad. So one of the possibility was probably she had a seizure and she was in a post-ictal state, but there was no big infarct as sir mentioned, and NIHS was a lot worse. So this outcome with such an NIHS was not expected. And second thing is a dose of tenecteplase in such patients where the weight is really beyond 90, and so there's no fixed dose that we should be giving, because for alteplase they say it's 100 milligram, but for tenecteplase they usually it's 20 milligram. So whether the dose should be increased further or whether the dose was appropriate.
No, so there is a gross mismatch between the imaging and the NIHSS.
Yes, sir. Yes, sir.
So did you look for other factors like hypoxia or sleep apnea because she's obese?
Yes, sir.
Her CO2 level or oxygen level, because they can also produce drowsiness.
ABG on admission was normal, sir. There was no CO2 retention. But definitely she is having obstructive sleep apnea because wake-up stroke, one of the pathophysiology for wake-up stroke is obstructive sleep apnea.
Yeah.
Considering her morbid obesity, I think that may be the reason for the stroke in this case.
So there is a gross mismatch here between NIHS, between the clinical picture and the MRI picture. So actually she fits into the Dawn criteria, because the infarct size is very small and the clinical deficit is very big.
Yes.
Huh?
Yeah.
Yes, sir.
So, Dr. Pradeep, I will actually the dose which is mentioned for tenecteplase is actually what the company is saying is 0.25 mg per kg. But the dose which most of us are using is 0.2 mg per kg. So I think with 100 kg, I think 20 was adequate enough. And makes economical sense also because 20 is what is available. Otherwise, you would have to buy another vial.
Yes.
So,
Sir, the MRI imaging which shows here, correct me if I'm wrong, it's a spin echo sequence actually. This will not be giving the correct nature of the image of the vessel wall. Actually, it should have gone to the source image. I am pretty sure that it should be a distal M1 or distal occlusion, because this is a spin echo sequence, and this is what that radiographer constructs actually. You should have shown the source image actually, which eventually would show you there will be some flow in the distal M1. Otherwise, that's a dramatic recovery would not happen with tenecteplase. This would have surely gone for some decompression. Correct me if I am wrong, sir.
No, that's true. But, we have a setup where we do not have a lot of ASL imaging and other things. So this was what was given to me, and I had to decide. And you said about radiologist. I will tell you that setup in my work, I don't have a radiologist in emergency.
No. This image is actually created from one source image actually. That is not done, this cannot be created. You should have gone to that source image and seen the vessel actually. There will be some flow.
Yeah, okay. So it is M1 or maybe distal M1. I don't think it will make so much of a difference.
Okay, sir.
So that you have thrombolized is very good. And this thing that you every time have to do mechanical thrombectomy only, I think it's a total myth. Because many times we have seen many times, and we have shown, we've had discussions here also, that these LVOs, large vessel occlusions, they recanalize after IV tenecteplase. So there is a big advantage of giving tenecteplase over alteplase in this type of situation. Not that alteplase doesn't work, it also works. But many trials have shown that large vessel occlusions do open up with IV tenecteplase, and therefore I would always want to give IV therapy prior to doing mechanical thrombectomy. And innumerable times we have seen that the vessels open up, and we are a resource poor country, and the costs are humongous for doing mechanical intervention versus IV. So there's a huge cost advantage. So definitely one would like to do IV thrombolysis whenever the indication is there, and the patients do really benefit many times. So this is again another prime example that IV therapy works in large vessel occlusion, and we should not deny this treatment. Now here, it's a little dicey because it's a wake-up stroke, and there are flare changes. So maybe it is already 6 to 7 hours. So IV thrombolysis is known to work even up to 9 hours. So there's that trial which shows that, but you have to have advanced imaging to do it. Unfortunately, here we didn't have, but I think you've got away very well and very this thing that you've opened up the vessel and you were bold, and it may not be the exact book picture. I mean, the book according to the book, but many times you have to hit, reverse sweeps and Dilshan scoops and all, and it works. They go for a 6, they go for a 4. Sometimes you get caught, of course. But this is a very, very good example of IV thrombolysis working in LVO. So many, many congratulations to you for having the guts to do it. And, we have this money problem in India. It's not like the West where, the government is paying or somebody else is paying, insurance is paying. So here it is an out-of-pocket expense. Many people can't afford it. So certainly I would use IV tenecteplase for large vessel occlusions, and many times it works. Many times it works. Yes, moderators, Anshul?
Yeah, I think what I would agree with you, sir. I think we are a very resource, because an average thrombectomy would cost in our hospital roughly about 5 lakhs. So
that is on day one, then after that ICU and this and
ICU
that.
And all that. So I think it's a very expensive proposition. I think, and I think listening to Dr. Abed, I think intra-arterial tenecteplase may also be a good option in certain cases. That may be much cheaper than doing a thrombectomy.
The dose is also very less, sir.
Yeah, dose is also less.
Yeah,
I was just contemplating, where we can't give we think we are reluctant to give an intravenous, maybe an intra-arterial.
Yes, sir. As just to add, sir, my professor used to say before, you might not get into the vessel, but the blood can get into the vessel. So thrombolyze first, then only get into any vessel. Sometimes you not get into it any vessel also.
Dr. Sharma, sir, would you like to add something?
Yeah, but just to ask a simple one question to Dr. Nasil, that most of the recommendations and right now the approval for the tenecteplase up to 3 hours by the DGCI. So what is your experience that can be used up to 4.5 hour or like alteplase even more than that? So
it's now approved in India up to 4.5 hours.
Okay.
So the approval has come from DCGI, I think last month.
Okay, sir.
And it is approved for use up to 4.5 hours. So that thing is out of the way.
I think they need to share us with this, because I think they have told us that it has come, but they don't have any official document of it.
Yes, sir. We are awaiting for the final documents.
But you showed me some document.
Yes, sir. So we have got, sir, DCGI letter also where they have accepted the recommendation from subject expert committee. We are expecting, sir, their label upgrade request, which we already done. It will take time, sir. I don't know how much time it will take. We were expecting this month, but so far we have not got. So the label upgrade, once it comes, then it will be official one.
Yes, sir.
Yeah. So Pradeep, how is the patient now?
So she's doing very well, sir. In fact, she came walking in the OPD for the follow-up, and she's on dual antiplatelets. And I think she was in September. I thrombolized her, and she has come just once walking in the OPD, and I'm still waiting for a second follow-up.
Yeah, but I think you need to investigate her for AF. Huh?
Oh, yes.
And you need to treat. You'll have to do a long-term Holter.
Okay.
Because this appears to be an embolic stroke. It came suddenly. M1 is the prime area where it gets involved. And the long-term Holter, a good echo, maybe even a TE. I like to do TEs more often. and treat her sleep apnea. Very important to put her on a CPAP, and because that is a high risk factor for stroke. She's also hypertensive, so she's got multiple risk factors. She diabetic?
No, sir. Only hypothyroidism was there.
Hypothyroidism, hypertension is there.
Only on presentation it was, sir, 190/100, and then.
But what is the ECG and echo and all that? Does it show LVH or
no,
whatever?
Sir. ECG was done. Holter was not done, but ECG did not show AF. Echo also was normal, sir. It was done by.
Yeah, I think you need to do a Holter long term, because the treatment changes. If you find AF, you'll have to anticoagulate her, and you'll have to. If a sleep study has been done, very good. If it's not been done, you should do it and then put her on a CPAP and improve her quality of life, because these strokes can recur, and its secondary prevention also is very important. So I think you have to take it 1 or 2 steps ahead further.
Yes,
but
sure.
Many congratulations to you, and it's really very heartening to see the LVO walking to the OPD after a few weeks or days. Very, very heartening. And otherwise, she would have been in a real mess. So you had the guts, slightly out of guidelines, but guidelines are guidelines. I mean, you have to use your brains when you have a situation on your hands, and I'm sure you have done it very well indeed.
Thank you, sir.
So many congrats.
Thank you, sir.
One question to Dr. Abid from my side, that his case initially was already on dual antiplatelet. So what was the prophylaxis he used after, because she had a stroke despite being on dual antiplatelet. So do you use the ticagrelor, because now they?
We have sent the patient for the verify now test actually, sir. Eventually it came to be aspirin as well as clopidogrel resistance. Both were resistance. And since she's already a CAD patient, both resistance, then now we have discharged her. She is on rehab with apixaban 5 mg BD and rosuvastatin 40 mg, high dose statins. We did not give her both antiplatelets right now because the verify now showed that both are resistance. That we did it on the 3rd day we sent it actually. It's a costly test actually. It cost around 20,000 here, but the cardiac people also were confused why we did not stand on a dual antiplatelet. We have to send her on with something. So now she is on a single anticoagulant, Novax, on apixaban 5 mg PD on rehab.
Don't you use the ticagrelor in patients who have clopidogrel resistance? Which the THEMS study has came and showing that we can use when we are finding clopidogrel to be resistant.
Both of them actually, the cardiac people also wanted to put her on apixaban. So anyhow, it was doing the job. So it's right now only on single anticoagulant, and that's what we have done actually. So there was a resistance for both of the drugs actually. The patient was affordable, so she was able to do all this under the sky. Otherwise, it's very difficult in our setup. So we do get unaffordable patients here.
Dr. Ichapuria, sir, so with your permission, can we close this session? Or
Yes.
Are there any final remarks?
I think we've had a wonderful discussion. Any closing remarks, Dr. Anshu?
No, I think we had a very wonderful discussion too, where difficult to treat cases, and I think both of them did very well, and both the patient did very well. So I think they thought little out of the box. I think Dr. Abid thought out of the box. I think that was really something to think.
Yes, sir. It was a great workshop, sir. And I would like to congratulate Dr. Abid, sir, and Dr. Tiwari, sir, for those difficult and interesting cases. I would like to thank also Dr. Ichapuria, sir, Dr. Sharma, sir, Dr. Rohatgi, sir, for taking some time out from your busy schedules and being with us today. And we would really like to work under your guidance, sir, for many such future programs. So with this simple note, we would like to close this session. Thank you, everyone, again. And bye. Good night. Have a
good night.
Thank you, sir.
Good night, everyone.
Thank you, sir.
Thank you, sir.
Hardik, we can close this later.